Dear jury, my name is Agnieszka Radziewicz, and I have pleasure to present you a lecture of topic Complications and Intervention in Patients with a Subcutaneous Implantable Cardioverter Defibrillator. At the outset of my presentation, I would explain what ICD and SICD are. Both devices are designed to recognize and stop life-threatening cardiac arrhythmias, thanks that they prevent sudden cardiac death. ACD stands for Implantable Cardioverter Defibrillator. Possible risk of ICD surgery may include infection and the implant site, swelling, bleeding, and bruising, and blood vessels damage from ICD leads. Due to complication after implantation ICD, SICD was developed. SICD stands for Subcutaneous Cardioverter Defibrillator, and this is how it looks. This device is entirely planted under the skin, leaving the vessels and heart untouched. It is recommended in particular situation, for example, difficult transvenous access, infections, complications after typical ICD, and among young people. At this slide, we have RTG photos of ACD and SICD. A transvenous ACD is implanted on the left shoulder area near the collarbone. In contrast to ICD, the pulse generator of SICD is implanted on the left side of chest next to rib cage, and just under the arm, and the lid is implanted under the skin above the breastbone. As we can see, SICD meets many requirements, but it also had its drawbacks. The aim of our study was to demonstrate them. The purpose is to assess complication and device intervention in patients with subcutaneous cardioverter defibrillator. Moving on to the methods, this is a prospective observational study. It includes patients with SICD implanted between October 2015 and September 2023 in Tertiary Cardiology Center in Poland. All patients were prospectively observed in single center SICD registry. All patients met the criteria for ICD implantation and with the current ESC guidelines. Median follow-up, our study is 539 days. Range is from 180 to 3,052 days. The study population consists of 86 patients with SICD. Median age our patients was 35. The youngest patient had 10 years and the oldest 86. 68.6% patients were male and 61.6% had SICD implanted in primary prevention of sudden cardiac death. 7 device-related complications were observed. Superficial wound infection were observed in 4 patients, but systemic infection requiring removal of SICD device was observed in 1. 1 patient needed lead revision due to the risk of device externalization and lead fracture. In 1 subject, device battery was suddenly excused. As we can see on this slide, other complication after implant SICD is inappropriate SICD intervention. Up to 6 months, 10 patients had appropriate SICD. They were due to ventricular tachycardia or ventricular fibrillation, but 4 patients experienced inappropriate SICD shocks. All of them were caused by atrial fibrillation with a rapid ventricular response. During long time follow-up, 7 patients had inappropriate SICD shocks. 2 of them were due to sinus tachycardia, 1 due to atrial fibrillation, and 4 due to T-wave oversensing. 1 patient had electrical storm, and 7 patients had appropriate SICD shocks. Moving to conclusion, device-related complications occur in 8% of patients with SICD. Inappropriate SICD shocks are observed in almost 30% of patients during a median follow-up of 2.5 years. The most common cases of inappropriate therapies of SICD are T-wave oversensing and atrial fibrillation with a rapid ventricular response. As we can observe, SICD is a safe device and presents a good alternative for typical transvenous ICD. Thank you for your attention.
So now we can proceed to the discussion. Do we have any questions?
One question, in your opinion, what is the main limitation of this method? I'm talking about SICD.
One more.
What is the limitation of this method for the patients? What is the problem, main problem?
The main problem was costs.
What was the main problem for the patients after the implantation of SICD, in your opinion, in the study?
Was inappropriate device interventions.
Okay, thank you.
Any more questions? Okay, so what was your own contribution to this work?
So I participate in analyze patients' medical data. I also enter data into the database. I was collecting follow-up, and to better understand this problem, we spoke with doctors who implant SICD and ICD and examined patients after implantation.
Thank you. Okay, thank you very much.
Thank you.
Since the authors of the paper number 2 resigned to present the paper, we can proceed to paper number 3, entitled Impact of Diabetes on Clinical Characteristics and Short-Term Results in End-STEMI Myocardial Infarction Patients.
Good afternoon, ladies and gentlemen. My name is Maria Wysocka, and I would like to begin this presentation with a quick characteristic of two conditions named in the title. The first characteristic is End-STEMI. End-STEMI is one of ACS, acute coronary syndromes. End-STEMI is MI, myocardial infarction, which, according to the fourth clinical definition of myocardial infarction, is characterized by abnormal cardiac biomarker setting, by acute myocardial injury by abnormal biomarkers in the clinical setting. Myocardial infection, we differentiate myocardial infection in STEMI and End-STEMI. Why is that? Because ST elevation is a very important marker of total occlusion of corporate artery, in which case the patient should be revascularized ASAP. And this line of thinking is reflected in the algorithm, in the guidelines. In the guidelines of ACAC, we see that STEMI patients are directed to revascularization ASAP, while in End-STEMI patient we evaluate the risk and wait for troponins, which can take up to 2 hours. So what's the problem? The problem is that according to this meta-analysis, a quarter of patients with End-STEMI have also total occlusion of corporate artery. When we see, so when we see the patient with total occlusion can go through this long lung, we lose time, and remember, time is muscle. So, the two words about diabetes. Diabetes is a group of metabolic diseases characterized by hypoglycemia, and hypoglycemia is notorious for organ damage, including damage to the heart and vessels. So, moving on to the material and methods. This paper was based on a larger register, and the inclusion criteria for this larger register were patients with first-time diagnosis of STEMI and STEMI who received PCI and age over 18. Exclusion criteria were withdrawing consent on previously undergone TBG or MI. So, in this population, the study population consisted of over 800 people, of which 31% had diabetes. A similar study done in STEMI population revealed that about a quarter of the patients had established history of diabetes mellitus. And our populations did not differ in regard of age and BMI, the population with diabetes and without diabetes, but they did, however, differ in a occurrence of stroke or TIA, peripheral artery disease, or chronic renal failure, which were more common in diabetic groups. However, dyslipidemia were more common in non-diabetic groups, which is non-surprising, seeing as the 3/4 of the conditions I mentioned are typical sequelae of DM, and the group without a major risk factor for ischemic disease, diabetes, had another major risk factor, which is dyslipidemia. In regarding to previous medical history with PCI, it was more common in diabetic group who were more likely to undergo PCI overall, and breaking it down to specific arteries, LAT was the only one in which there was statistically significant difference. Results. Total occlusion of infractures are the occurrence of prevalence of total occlusion of infraction artery did not differ statistically into subpopulation. The overall prevalence of total occlusion in this population were lower than in the ECS meta-analysis, which leads us to the conclusion that the NSTEMI is as imperfect marker of non-total occlusion of infraculated artery in both diabetic and non-diabetic group. Short-term, moving on to short-term results, the groups did not vary in regards to prevalence of stroke during the hospitalization. However, mortality in-hospital mortality were higher in the diabetic groups. The risk was raised about 2 times. In the previously mentioned study on STEMI population, the results were the same. However, the overall mortality were higher in this study. And in this study, in this meta-analysis, also mortality for diabetic patients were higher, and the prevalence of stroke did not differ to subpopulation. So what's next? Next will be to isolate the group of diabetics without complication to see whether the disease or the complication include worse outcome for this patient, and also inquire whether one artery is predisposed to being involved in the MI. This may be graphically. Thank you for your attention, and now it's time for questions.
Proceeding, yeah, do we have any questions?
Thank you for this great presentation. Would you like to say us the key message from this, the main conclusion, the most important conclusion from this study?
The most important conclusion is that the NSTEMI is that the diabetes does not impact how good NSTEMI characterize the patient whenever its artery is occluded or it isn't occluded, as it is a problem whenever the artery is totally occluded or not.
Yeah, it's a very important problem because some patients with presented as NSTEMI actually have got a completely occluded artery. You're right, and the conclusion is that based on this diabetic status, we cannot differentiate these both groups. Yeah.
Yeah, that means that the diabetic patients do not need special treatment in case of myocardial infarction. They're not special treatment. I mean, there is no thing that inquire that diabetic patients should be put in group of higher risk of total occlusion when they have NSTEMI.
But yeah, okay. Could we really conclude it from this study?
No, we could not. But it would. But if the study was positive, it would be. Yeah. It could be an impulse to do a bigger study, and then we could.
You're right. Yeah, you're right. You're right. According to this NSTEMI presentation, because mostly the occluded artery, unrecognized by ECG, it is a circumflex artery which is behind the heart. And usually it could be visualized on as STEMI when you use additional leads like V7, V8. Do you have in your material this type of ECGs, or it was limited to just regular one, V1, V6?
No, it was no. It is all based on the regular ECG.
Okay, thank you.
Thank you very much. Do we have another questions? Okay, so what was your own contribution to this work?
Well, my tutor provided me with counted with the amount of patients in its group and first statistics, but most of the statistic p-value were calculated by my own. I took part in creating the larger register by harvesting data from the hospital and also putting it in the Excel file. And in this work, I did the research of the scientific space for the discussion.
Okay, thank you very much. Now we can proceed to the paper number 4, entitled Rhythm Disturbances Related to Cardiac Myxoma and its Surgical Removal.
Ladies and gentlemen, honorary jury board, I have immense pleasure to present you the results of our work retrospective analysis concerning the topic of cardiac myxoma surgery removal and its complications, especially rhythm disturbances. The cardiac myxoma is ultra rare, although the most common primary cardiac tumor. It only happens about 20 times a year in Poland, in our country. So, as you can see, it's ultra rare condition. And the best treatment for, and only treatment for cardiac myxoma is its removal, surgical removal, either by classic sternotomy or minimally invasive approaches. On the figures you can see some cardiac myxomas. We conducted, as I said before, retrospective analysis of the paper and electronic registers from 35 years from the single center, and then we conducted statistical analysis in the IBM SPSS software to find the possible factors that impacts the complication profile after the surgery. The baseline of the patients, as I haven't mentioned before, that the cardiac myxoma is present mostly in the women, and similar statistics were seen in our cohort. And the other comorbidities are pretty similar to the standard cardiothoracic patient population. Only interesting fact, pretty surprising to me, was that only one of the patients of our pretty large cohort had the recurrence of cardiac myxoma. But we don't have the follow-up checkups of all of the patients, so we can be sure that the cardiac myxoma, due to its high chance of the recurrence, haven't came back in those patients. They only weren't operated at our center next time. The additional procedures conducted during the cardiac myxoma removal varied. The most common one was patent foramen ovale occlusion. And then on the figure we have presented the the locations of cardiac myxoma. The most common one was the interatrial septum. It happened in this place in more than 80% of our population, and only 2 of our patients have had 2 cardiac myxomas during the surgery. There are complications presented in the picture, in the table, and only 12% of the patients had any complication after the surgery. But I will focus more on the EKG changes post and preoperative. Before the surgery, 62 patients had any right disturbances, including mostly atrial fibrillation and ischemic changes, as in general population, those are the most popular right disturbances. EKG changes, sorry, obviously the ischemic changes aren't the right disturbances. And after surgery, 4 of those changes resolved despite no ablation, etc. So presently the cardiac myxoma was resulting in those right disturbances. The new EKG changes occurred in 13 patients, and there was huge variety of the different arrhythmias, including atrial fibrillations, LBBB, RBBB, and others. And we conducted, as I said before, the statistical analysis, and obviously we found that the bigger diameter of the cardiac myxoma resulted in increased, it was positively correlated with increased in the number of arrhythmias post-operatively, although it's pretty obvious outcome, and localization, on the other hand, had no impact on the arrhythmia type and occurrence. At the end of my presentation, I would like to mention that despite the cohort is pretty big, basing on the epidemiology of the cardiac myxoma, we had, in almost all the patients, we had no follow-up due to the retrospective character of our study. So, as you can see on this figure extrapolated from the understudy, we can see the atrial fibrillation onset was delayed in the many years after the cardiac myxoma surgery. So we are thinking about conducting the prospective analysis of the patients operated at our center, but due to the small number of the interventions a year, it will be a really long study if we will manage to conduct it. So thank you for your attention. And dear jury and honorable audience, if you had any questions concerning my work, I will be really happy to answer all of them. Thank you very much.
Thank you. Do we have any questions? Yep.
I would like to ask one question. Can you hear me?
Yes, please. Please, Tomek.
I would like to ask, because you presented that during the removal of myxoma, there were several other procedures like CABG or mitral valve replacement. And my question is, did you analyze the impact of these additional procedures on the post-operative atrial fibrillation?
We haven't analyzed the impact of those procedures on the exactly the right disturbances, but we analyzed the impact of those additional procedures on the overall on the complication rate, not only the arrhythmias, but all of the complications, and we had no statistically significant results. And thank you very much for your question.
Thank you.
So one question more. You have only patients with atrial fibrillations. No any case with atrial flutter in this population? Or it's in one group, atrial flutter and atrial fibrillation?
As I think the atrial flutter was mentioned and right there in the other arrhythmias. Yeah.
Okay. Okay. Thank you.
Thank you. So last question, what was your own contribution to this work?
As for the type of the study as retrospective analysis, I collected the paper and electronic registers, and then I conducted the statistical analysis, because unfortunately I'm only a medical student and I can't conduct the surgery, so I only analyzed the data and collected it.
Okay, thank you very much.
Thank you.
Thank you very much. Now we can proceed to the paper number 5, Contemporary Management of Patients with Discharge of Implantable Cardioverter Defibrillators.
Good morning, ladies and gentlemen. My name is Mateusz Drabczyk, and I have a great pleasure to present the results of our research study entitled Contemporary Management of Patients with Discharge of Implantable Cardioverter Defibrillators. ICD therapy has become the treatment of choice in patients at risk of developing ventricular malignant arrhythmias as a prevention of sudden cardiac death. According to European Society of Cardiology guidelines, the primary prevention of sudden cardiac death embrace ICD implantations in patients, firstly, in case with symptomatic heart failure and left ejection fraction below 35%, despite at least 3 months of best medical therapy. Secondly, in case of coronary artery disease or dilated cardiomyopathy at least 40 days after myocardial infarction. Or thirdly, in case of asymptomatic chronic heart failure of ischemic etiology, also at least 40 days after myocardial infarction, or with non-ischemic etiologies in whom left ejection fraction is below 30%. On the other hand, the secondary prevention concerns the survivors of ventricular fibrillation or hemodynamically unstable ventricular tachycardia. Despite the growing number of ICD implantation, the available data concerning the treatment after the occurrence of ICD discharge is very limited. What we know is that ICD discharges may be triggered by ventricular fibrillation or ventricular tachycardia caused by active myocardial ischemia or myocardial scar, as well as hypokalemia, hypoxia, inflammatory response, or may occur as an inadequate response to ICD malfunction or supraventricular arrhythmia such atrial flutter or fibrillation. The aim of our study was to assess the characteristics of patients admitted following ICD discharge, focusing on myocardial ischemia, since the coronary artery disease represents one of the main etiologies of ICD implantations. Furthermore, we wanted to evaluate the predictors of the recurrent VT in this group of patients. Our retrospective study entails 81 patients hospitalized in Upper Silesian Medical Center in Katowice between 2015 and 2023. The primary inclusion criteria for the study was a history of high-energy discharge as the primary reason of hospital admission. The major exclusion criterion was ST segment myocardial infarction as a cause of ICD intervention. We divided the selection of 81 patients into several groups based on whether they underwent coronary angiography or not, had the recurrent VT during hospitalization or not, or underwent the catheter ablation due to VT or not. Afterwards, we compared the mentioned groups in the final analysis. Our primary clinical endpoint was the recurrence of ventricular tachycardia during hospital observation. As for general characteristics, among our study population, 70 patients were male with a mean BMI of 28.4, left ventricular ejection fraction of 29.5, and comorbidities mentioned in the slide. The etiology of pacing device implantation was coronary artery disease in 55 patients and non-ischemic 1 in 26 ICD recipients. Moreover, 34 patients underwent coronary angiography, 21 patients experienced the recurrent VT, and 36 patients required the catheter ablation due to VT. Let's now turn our attention to the comparison of clinical variables between the group of patients who underwent coronary angiography and who did not. Notably, patients who were referred for urgent coronary angiography had mainly ischemic heart failure as an indication for ICD implantation. Moreover, they were significantly more often diagnosed with hyperlipidemia, diabetes, had a history of myocardial infarction, as well as PCI or both PCI and CABG in the past. If we now look at the analysis of different variables depending on the relapse of ventricular tachycardia, we observe that patients who experienced the recurrent VT during hospitalization had mainly a higher New York Heart Association class and greater number of premature ventricular contractions in Holter monitoring, as well as higher white blood cells level, serum creatinine concentration level, along with lower eGFR level. Moreover, they had greater prevalence of left ventricular hypertrophy, chronic kidney disease, and they experienced more often ICD reintervention during hospitalization, as well as underwent catheter ablation due to VT. What is more, it's worth noting that the univariate analysis showed that the recurrence of VT was predicted by impaired renal function, left ventricular hypertrophy, white blood cells level, and New York Heart Association symptomatic class. Additionally, the logistic regression analysis confirmed that NYHA symptomatic class and left ventricular hypertrophy were independently associated with the relapse of VT. Moving on, the comparative analysis of different clinical variables among patients who underwent catheter ablation and who did not due to VT, it demonstrated that patients with coronary artery disease underwent catheter ablation more frequently than those with non-ischemic etiology, as well as the prevalence of electric storms was significantly higher in this group. Furthermore, among patients who required catheter ablation, the history of myocardial infarction was more prevalent. They had significantly greater level of the triglycerides, creatinine, and lower level of eGFR. In conclusion, I would like to draw your attention to the fact that our study suggests a potential role of myocardial ischemia in exacerbating ventricular arrhythmias in ICD patients, which highlights the importance of coronary evaluation. Furthermore, the presence of left ventricular hypertrophy and prior NYHA symptomatic class are associated with the relapse of ventricular tachycardia. Thank you for your attention. If you have any questions, I will be honored to answer them.
A really great presentation. Good work. Thank you. And,
Thank you.
Congratulations. I have a very basic question. Did you check for normal distribution of all this data?
As far as I'm concerned, we did not actually.
Because you have used very sophisticated statistical methods, but some of them require a normal distribution on the background. This is the first thing. The second thing is the variable, the functional class, the New York Heart Association class. Yeah, you know this. There are 4 different classes. Yeah.
Yes, exactly.
But how we cannot use 2.2 expression like 2.9 NEHA class. It doesn't have any sense.
All right. Thank you for this comment. I will take it for future consideration.
Thank you.
Thank you.
Any more questions? Yep.
Question about your personal opinion about after this study, the ablation. All patients after episode of ventricular tachycardia need ablation or not, in your opinion? If not, which one patients don't need it?
I think the ablation is needed in very significant ventricular tachycardias, especially to hemodynamically unstable patients. For the other ones, the pharmacotherapy should be enough. Thank you.
Okay, thank you.
Any more questions? Okay, so the last classical question, what was your own contribution to this work?
Thank you. I was responsible for preparing the database for data collection of patients. Afterwards, I certainly took part in the data acquiring. And I, of course, prepared the presentation for today and the speech as well. Thank you.
Thank you very much. So we can smoothly proceed to the next presentation. I invite the presenter of the paper entitled Acute Pulmonary Embolism, Are We Strong Enough?
Dear jury, dear audience, my name is Łukasz Papież. Today I'm pleased to present to you our recent study called Acute Pulmonary Embolism, Are We Strong Enough? Pulmonary embolism occurs when a blood clot disrupts the blood flow in the pulmonary arteries or the branches. It's a life-threatening diagnosis. In our study, we focused on acute pulmonary embolism with high or intermediate high early mortality risk. What can we do about pulmonary embolism? There's a variety of possibilities: anticoagulation, systemic thrombolysis, surgical treatment, or hybrid therapy. It's crucial to make a decision considering the benefit to harm ratio of every treatment option, while also maintaining optimal short and long-term prognosis. And this is where PERT comes into play. PERT stands for Pulmonary Embolism Response Team. The initiative was first founded in Boston, Massachusetts back in 2013. PERT is a multidisciplinary approach where the goal is a quick consultation and selection of therapy. For example, cardiologists, interventional radiologists, cardiac surgeons come together for shared decision-making to achieve better outcomes. Our study revolves around the Silesian PERT initiative, founded in 2020. Since then, around 100 patients were consulted. In 2022, a notable procedure took place where our team, led by Dr. Marek Grabka, successfully performed a pulmonary thrombectomy on a pregnant woman, saving both the mother's and the child's life. So the objective of our study was to analyze the work of the Silesian PERT and the chosen treatment strategies. Because it's the first stage of our study, we wanted to acquire some simple takeaway numbers to see what's been going on in the past 4 years. We gathered our information from the database of the first cardiology department in the Upper Silesian Medical Center in Katowice, focusing on patients with acute PE, hospitalized since the establishment of our PERT. Our methodology covered criteria like the pulmonary embolism severity index, the applied treatment, the cost of hospitalization, and contraindications for thrombolysis. Of course, we were most focused on high-risk and intermediate high-risk patients. Moving on to the results of our study, as of January 2024, a total of 222 acute pulmonary embolism patients were hospitalized in our unit. 47.7% were of high or intermediate high risk. That equals a number of 106. These patients needed consulting by the PERT initiative. Out of 106 patients consulted, 43 were of the highest risk. That's almost 20% of all the acute PE patients, in my opinion, a significant percentage. Moving on to the core of our study, the amount of invasive procedures performed by our PERT initiative is 19, 14 for high risk, and 5 for intermediate high risk. Additionally, incidences of subsequent transcatheter thrombolysis were 5 times in the high risk group and 3 times in the intermediate high risk group. One of those 5 cases was the previously mentioned pregnant woman. Here's a comparison of the patients consulted by PERT, divided into 3 therapeutic subgroups: heparin only, heparin plus systemic thrombolysis, and invasive procedures performed by PERT. So the heparin only subgroup happened to be the largest group, and also happened to be the oldest on average, while on the other hand, the heparin plus systemic thrombolysis subgroup was the youngest and had the lowest SPECI score. Finally, patients treated with invasive methods by PERT had the highest SPECI score, and I'm sorry for that point, I can't figure this out, had the highest SPECI score and the highest rate of contraindications for thrombolysis. When it comes to the course of hospitalization, it was quite similar between the heparin-only subgroup and the systemic thrombolysis with simultaneous heparin infusion subgroup, whereas patients treated with invasive methods by PERT were hospitalized the longest, needed further hospitalization in other departments more often. Additionally, they had the lowest rate of hospital discharge and the highest in-hospital mortality. And this brings me to the following conclusions. The use of invasive treatment by PERT for patients in acute pulmonary embolism is limited. The dominant treatment option is the use of heparin. A possible explanation for that is that PERT is a relatively new initiative in our unit, so there's still a lot of experience to be gained. More experience gained equals more confidence in decision making. Additionally, the period of COVID-19, the pandemic, also slowed down the development of our program. So doctors, to avoid risk associated with invasive procedures, had as their go-to option heparin treatment. Although invasive procedures offer a fast and astonishing improvement of the patient's conditions. I believe that in the future, and as our study continues, there will be a higher frequency of performed invasive procedures by PERT, and the outcomes will be even better. Here are the studies that we drew from. Ladies and gentlemen, this is all I wanted to share with you. Thank you for your attention.
Thank you very much. Now we can proceed to discussion. Do we have any questions from the jury? Yep.
Thank you. Congratulations. Excellent job and your presentation, but please try to explain why did you conclude that heparin is overused? And what does it mean, overused?
We mean by that as I've discussed the data with our tutor, we came to the conclusion that we need to act more aggressively and treat some of the groups that were treated only with heparin with an invasive fashion, because there were deaths in the heparin-only subgroup, and we think that by using the invasive method, those people, those 9% that died, they could be saved if there was a firm decision.
I think that you thought that only heparin treatment, yes?
Yes.
because all of our patients with pulmonary embolies have to be treated with heparin or other anticoagulation.
Yes,
so
I mean mainly with heparin.
You cannot say overuse because it has to be used.
All right, I understand. I mean that heparin was only considered and that there should be an invasive treatment.
Yes, this is only my suggestion. If you will think about the publish this paper, to a little bit change your conclusion. It's not overused because, as I told you, all of our patients have to be treated with heparin. Maybe an invasive method, especially in patients in high risk, should be used with higher frequency. This conclusion from your paper. Congratulations. Thank you.
Thank you very much.
Thank you very much. Do we have other questions? Okay, so what was your own contribution to this work?
So I would describe my own contribution as 100%, but what do I mean by that? I, as well as other members of my team, we took part in every stage of the study. So we could perform this study in an optimal fashion from learning from our tutor what PERT is all about, because I as a student didn't know that such an initiative exists. We reviewed the literature, then we collected the data, we prepared the abstract, and of course the presentation.
Thank you very much. And heading to the next presentation, paper number 7, percutaneous LAAO with the Watchman FLX device in patients with AF and with contraindications for OAC.
So good afternoon, ladies and gentlemen. My name is Marta Hamera, and today I would like to present our research about percutaneous left atrial appendage occlusion with Watchman Flex device in patients with atrial fibrillation and with contraindication for chronic oral anticoagulation. Atrial fibrillation is the most common cardiac arrhythmia, which increases the risk of ischemic stroke fivefold. Moreover, atrial fibrillation-related strokes are connected with more significant morbidity and mortality. In non-valvular atrial fibrillation, over 90% of stroke-causing clots originate from left atrial appendage, a blind pouch of various morphology, which is a remnant of embryonic development of left atrium. Therefore, atrial fibrillation patients with high thromboembolic risk should be treated with long-term oral anticoagulation. Despite the benefits of this therapy, there is a group of patients with various contraindications for chronic oral anticoagulation. Recently, the percutaneous left atrial appendage occlusion should be researched that it's a good method for the reducing risk of thromboembolic complications in patients who are not candidates for long-term oral anticoagulation. According to current European cardiology guidelines, the left atrial appendage occlusion may be considered in patients with atrial fibrillation for stroke prevention who are not suitable for chronic oral anticoagulation. Therefore, in this study, we aim to evaluate one-year clinical outcomes of transcatheter left atrial appendage occlusion using Watchman Flex device in patients with atrial fibrillation and with contraindication for oral anticoagulation. This registry is one-center observational study conducted. The data included 138 consecutive patients with atrial fibrillation and high thromboembolic risk, which was defined as 3 or more points in Chadva scale, and who are not suitable for chronic oral anticoagulation. Patients were performed left atrial appendage occlusion with Watchman Flex device between July 2019 and April 2023 during planned hospitalization. Moreover, all of the patients were assessed by transesophageal echocardiography before hospital admission. Median follow-up was 1 year, and the primary endpoint which was used to assess the safety and efficacy of this procedure was incidence of ischemic stroke. The secondary endpoints were the rate of death and the rate of major bleeding, which was defined as any bleeding requiring hospitalization or blood transfusion. By looking at the baseline characteristic, we can observe that the mean age of study population was 75 years and almost 61% were male. The mean Katowice score was 4.2 and the mean Hasbet score was 3.1. Prior ischemic stroke was present in 30 patients and clinically relevant living in 106 patients. The most common comorbidity in this population was hypertension, and the mean left ventricular ejection fraction was 49%. Relating to main contraindication for chronic oral anticoagulation, the most common ones in this registry was clinically relevant bleeding, with the gastrointestinal bleeding as the most frequent, labile INR, and severe chronic kidney disease or liver disease. Based on procedural data, the implantation was successful in all of the patients. The mean Watchman Flex devices was 25.1 millimeters, with the most common size 27 millimeters. The median procedural time was 50 minutes. As for periprocedural complications, it occurred in 4 patients, and all of them was associated with venous access site. During 1 year follow-up, the study's primary endpoint, ischemic stroke, occurred in 3 patients. What's important, all these patients had elevated thromboembolic and hemorrhagic risk. It means Katowice score of 6 and Hasbet score of 4. Additionally, 2 of these patients had multiple comorbidities, history of ischemic stroke, gastrointestinal or intracranial bleeding, labile INR, and abnormal renal or liver function. The major bleeding occurred in 8 patients, with the gastrointestinal bleeding as the most frequent, and the rate of death was 3.6%, whereby 3 cases of patients' death were associated with the compassion of severe chronic heart failure. 1 patient who died was in advanced age with multiple comorbidities and thromboembolic and hemorrhagic risk higher than normal. And 1 cause of death was unfortunately unknown. To sum up, this registry of data suggests that percutaneous left atrial appendage occlusion with Watchman Flex device is effective and relatively safe procedure for patients with atrial fibrillation and with contraindication for chronic oral anticoagulation, connected with the reduced incidence of ischemic stroke and bleeding complications at 1 week follow-up. However, further prospective studies with long-term follow-up are required to confirm this method as safe alternative option for patients with atrial fibrillation and high thromboembolic risk who are not suitable for chronic oral anticoagulation. So that's all. Thank you for your attention. And if you have any question, I would like to answer.
So proceeding to discussion, do we have any questions?
Excellent presentation, congratulations. But please, would you be so kind and show us your last slide? Okay, tell me, why did you conclude that left atrial appendage occlusion reduced the rate of stroke in 1 year follow-up? It should be some kind of comparison.
Okay, so...
Yes, please.
Okay, so I think that when looking at the baseline characteristic, a lot of patients had quite a high Katowice score. It was 4, but also 5, 6, and some patients with 7.
Okay, thank
scores.
you. Thank you.
Another questions?
It was a good answer.
Okay.
Okay, so what was your own contribution?
Okay, so my contribution to this study was collect data and create database, then also collect follow-up during the phone calls, and also search some other studies and compare the results, and of course write the abstract and prepare the presentation.
Thank you very much.
Thank you.
So we're not slowing down and proceeding to next paper, number 8, left atrial appendage occlusion using predictive simulation technology and AI, single center experience.
Ladies and gentlemen, dear jury, my name is Miłosz Kastrzyk and I represent the Faculty of Medical Sciences in Katowice, Medical University of Silesia. And today I'd like to present you our research on left atrial appendage occlusion using predictive simulation technology and AI. So without going into details of the LAAO, because previous presenter already explained that very quickly and good, the EASC guidelines on law are that it may be considered for stroke preventions in patients with atrial fibrillations and contraindications for long-term anticoagulant treatments such as intracranial bleeding without a reversible cause. The aim of our study was to analyze the clinical course of LAAO using traditional approach or the predictive simulation with AI-based anatomical measurements of the CT scans with the program called FEOPS. Our study was a retrospective analysis of 65 patients aged between 59 and 92 years old who underwent the procedure in the first department of cardiology in Katowice, Ohio between May 2018 and October 2023. The FEOPS planning was performed on 18 out of 65 patients, which represents 27.7% of the total. And then the follow-up was conducted on the patients from the given clinics. The follow-up was to analyze the transesophageal echo, typically 2 to 3 months after the procedure. And then the further follow-up was to analyze the distinct complications such as stroke, thromboembolic incidents, myocardial infarction, death, and bleeding. This is the graphical visualization of our occluder that we used in our study. It's Amplatzer amulet. As you can see, it's built out of 3 main parts. The disc that completely seals the ostium of the left atrial appendage, lobe that fixates the device in the appendage, and waist that maintains the tension between the 2 parts. So what is FEOPS? It's a structural heart planning program. It's based on the CT scans, and with the help of artificial intelligence, it provides the visualization of how the device will be placed in the heart of the patient. It helps to predict the device position, frame deformation. The specialist can also see how different sizes of the devices will look in the left atrial appendage, and it also, according to studies, improves successful rate of the procedure. The advantages are, first of all, that it is a standardized process. It's not affected by the operator preferences or experience. It's scalable, reduces preparation time for the procedure, and allows TE not to be performed. And as I said, according to studies, procedural efficiency reaches 100% in the CT plus simulating planning and 95.9% in standard transesophageal echo planning. Here is an example from one of our patients. How does the measurement look like? So first, the CT scan is performed. With the help of AI, the anatomical ostium and landing zone is measured, and then the program visualizes the heart and all the important anatomical sites in the heart for the specialist to better prepare for the procedure, and then you can choose which sizes of the occluder you want to simulate. The red area of the device corresponds to the area least adhesive to the heart wall, so based on that the specialists can choose the right device that will seal the left atrial appendage most. When it comes to patients' characteristic of our group, the mean age was 76.54 years old, 25 out of 65 were female and 40 were male. The mean BMI was 27.74. 3 of our patients had atrial flutter instead of atrial fibrillation. However, they had reports of atrial fibrillation in their history. The mean Hasbled score was 3.18 and CHA2DS2-VASc 4.69. The prior cardiovascular incidents were commonly present in our group. However, the most important ones are the bleeding incidents, which act as an indication for the procedure, and 71% of the patients presented with bleeding on anticoagulants. The most common site of the bleeding was the gastrointestinal tract and cephalic bleeding. The less common were hematuria, nasal bleeding, hemoptysis, and bleeding into the eye. And as you can see, 20 of the patients did not report bleeding. If not bleeding, then what? 7 out of 20 patients were diagnosed with aneurysm. Basically, most of them had the aneurysm in the central nervous system. 4 had active hematological malignant disease, and the others included patients with very high risk of incidents, and that may be the cause of the bleeding. It was elderly patients, so the specialist decided that they should undergo the procedure. Drugs that mostly caused the bleeding were NOACs and lower molecular weight heparin. The less common ones were acetylsalicylic acid, clopidogrel, and vitamin K antagonists. The most common sizes of occluders used in our study were 25, 20, 22, and 28 millimeters. The other, the smallest and the highest sizes were not commonly used. When it comes to procedural characteristic and the device implantation itself, we observe little to none of the complications. Excessive protrusion was visible only once in the standard group, and residual leakage once in Phelps group. The uncovered trabeculation didn't occur once, as well as embolization and removal of the device. And the meantime of the procedure in the Phelps group was 85.5 minutes, and in standard group 92 minutes. But it's important to note that the measured time was from the admission to the hemolab until the return to the home ward. Then the periprocedural complications, we observed total number of 7 complications. 6 of them occurred in the standard group, which included 4 pericardial effusions, 2 pericardial punctures, and in the Phelps group it was only one case of hematoma in the puncture site.
Please proceed to conclusions.
So to conclude, LAA is a relatively safe procedure that can provide alternative for stroke prevention in patients with contraindications for anticoagulants. Modern imaging methods combined with the use of artificial intelligence made the procedure more efficient and faster, and we hope that it may be possible in the future to abandon TE altogether in favor of non-invasive imaging techniques. Thank you for your attention. This is our references, and I'm very happy to answer all your questions.
So, do we have any questions from the jury? Yep.
Congratulations, great work. One small remark, categorical variables don't have decimates. Again, the same with, you know, CHA2DS2-VASc, Hasbled,
I realized that
class,
while preparing.
Everything. Great. Do you consider taking into account the learning curve of operators as a factor? Because as I know, probably the Phelps has been used for the last procedures, and the first part of the procedures has been performed by this group without this support.
You mean that the first procedures performed in this
in this
were made without?
And it was the beginning of the method. So maybe which is normal. Every operator has his own learning curve. Maybe it has been an influencing factor somewhere in the past.
Yes, I think it's very influencing factor. However, the mean time in the standard and FAIRS group of the follow-up was basically almost the same. Me personally, I think it is more as the study acts more as a describing study, and further when we in a year or two we hope to come back to the results and sum up it with the new data that we will obtain, and maybe then we will be able to do statistical analysis of this, because the group was too small to do statistical analysis.
You're right, but once again, congratulations. Good, thank you.
Thank you. Any more questions? Okay, so tell us something about your contribution.
My contribution to this work was to divide work evenly between all of the members of our team, so no one would be left behind. And basically, every member of our team was doing the same job, so gathering the data and analyzing it. And I was also responsible for the preparation of the presentation and presenting it here today.
Thank you very much.
Thank you very much.
So, I invite the presenter of paper number 9, myocardial injury after complex percutaneous treatment of calcified coronary lesions.
Dear ladies and gentlemen, my name is Veronika Biel, and I am honored today to present you the outcome of our work on myocardial injury after complex percutaneous treatment of calcified coronary lesions. We decide to take a closer look on two types of such a treatment, which is rotational atherectomy and orbital atherectomy. Firstly, I would like to give you a closer and better insight how those techniques work and why do we actually need them. So the most challenging lesions to treat during PCI are associated with severe calcification processes. Therefore, they are hard to remove. The procedures such as rotational atherectomy and orbital atherectomy were invented. They enable the bulking of the calcified plaques and thus to facilitate stent implantation. The risk of stent malposition and stent under expansion is significantly lower when OA or array are performed before stent implantation. The rotational atherectomy is an older technique used more often than orbital atherectomy, which is quite new. First time it was used in 2021 in Poland, and right now is performed only in a few hemodynamic centers in Poland. What is interesting and was one of the reasons of our work is the fact that fragmentation of calcified plaque to the microcirculation is thought to be associated with higher risk of myocardial injury. However, this collocation hasn't been yet documented. Here you can see the main differences between two types of those procedures. So firstly, the device used during rotational atherectomy is called rotablator. It is a diamond encrypted burr that can move only forward. It works at speed ranging from 140,000 up to 190,000. On the other hand, the device used during orbital atherectomy is a crown that rotates in orbital motion. It can move forward and backward and can work only at 2 speed, 80,000 and 120,000. Oh, no. Okay, sorry. To summarize, the aim of our study was to compare rotational atherectomy and orbital atherectomy, focusing on myocardial injury reflected by troponins level and consequent periprocedural myocardial infraction and injury after atherectomy. To do that, we revised the data of 20 patients, 10 consecutive patients that underwent rotational atherectomy and 10 consecutive patients that underwent orbital atherectomy. For each patient, the levels of high-sensitive troponin were measured 8 hours and 24 hours after the procedures. Periprocedural myocardial injury and infraction were defined according to the fourth universal definition of myocardial infraction. No statistically significant differences in patient characteristics between two study groups were observed. When it comes to procedural characteristics, the orbital atherectomy was observed to have increased total runtime, higher number of bare passages, as well as increased radiation exposure. All procedures were successful. However, myocardial injury was observed in both study groups with tendency toward higher troponins level after orbital atherectomy. The periprocedural myocardial infraction was numerically higher in the OA group. However, the difference wasn't statistically significant. It could be caused by the fact that study groups were quite small. If the study population would be larger, the difference in PMI occurrence could appear to be statistically significant. The patient with PMI had higher CCS, more often suffer from triple vessels disease. Also, the modification of left main artery or LAT were more often performed in this group of patients. And all of the dissection that occurred during the procedure only happened to the patient that suffered afterwards with periprocedural myocardial infarction. And the conclusions that I want you to remember after this presentation is the fact that rotational atherectomy and orbital atherectomy are equally effective in modifying calcified plaques. Both array and OA have higher risk of periprocedural myocardial injury and infraction than a standard PCI. Myocardial injury and PMI was observed in both study groups. However, its clinical role has to be determined in long follow-up. And as I told you before, our study groups were quite small, therefore our research was actually a pilot study. However, its results encouraged the further research to be done. And the method of treatment should be chosen based on patient conditions, the anatomy of coronary arteries, as well as experience and knowledge of operator and clinical center. Thank you very much for your attention.
So, do we have any questions from the jury? Okay, so what was your own contribution to this work?
So my own contribution as my colleagues was firstly to gather the data of patients, then to analyze those data and made presentation and abstract.
Yeah. So thank you very much. And so, last but not least, paper number 10, stenting of native coarctation of aorta in adult population, comparison of covered and bare metal stents.
Dear committee, ladies and gentlemen, my name is Michał Kapałka. I'm representing the Department of Pediatric Cardiology and Congenital Heart Defects from Faculty of Medical Sciences in Zabrze, and I'm honored to present results of stenting of native coarctation of the aorta in adult population, in which we compare covered and bare metal stents. Just to have some introduction to the topic, coarctation of the aorta is one of the most common cardiovascular congenital defects, and it is usually diagnosed and treated in childhood. But there is 3% of patients who remain asymptomatic until adulthood when they start suffering hypertension or heart failure. And those patients, after echocardiographical assessment, if the peak-to-peak gradient across the coarctation narrowing is greater than 20 millimeters of mercury, they are qualified for percutaneous stenting of native coarctation of the aorta. But the guidelines does not recommend any particular type of stent, and we have basically two types of them, the covered stents. The advantage of these stents is that we can put greater pressure during the explantation, and in bare metal stents there is no risk of occlusion of one of aortic branches. Also, literature does not resolve this problem, whether bare metal stents or covered stents has a lower reinterventional rate. So aim of our study was to evaluate short and mid-term effects of native stenting of native coarctation, and to evaluate reintervention rate in both groups. We retrospectively analyzed 37 patients who received stenting for native coarctation of the aorta. In median age of 34 years old, they were mostly male patients. Almost 50% of them had treated hypertension. Almost 20% had coexisted bicuspid aortic valve, and median follow-up totaled 11.4 years, and it does not differ between the groups. In the covered stents group, it was 10 patients, and in bare metal stent, it was 27 patients. All procedures were successful. There was no peri-procedural complications, and notably, 22% of procedures, they were life-saving procedures. And what is interesting, group does not differ in the pre-operative gradient, in degree of stenosis and in weight, but they differ in age. The patients receiving covered stents were significantly older than patients with bare metal stents, and we can explain that with the higher occurrence of atherosclerosis or calcified lesions in older patients, what lead us to use covered stent. Moving to hemodynamic data, narrowing of the coarctation was medianly widened by 7.8 millimeter, what caused median gradient decreased by 32 millimeters of mercury. And here we can see the comparison of the median gradient decrease, which was greater in bare metal stent group with 31.2 millimeters of mercury, comparing to 26.9 millimeters of mercury in covered stent group, and the difference was significant. And reinterventions, 35% of patients required reintervention. It was 11 procedures of balloon angioplasty and 2 covered stents implantation in the course of aneurysm management. Bare metal stents group has a higher reinterventional rate with 44.4% comparing to covered stent with 10% of reinterventional rate. And the difference was at the borderline of significance. And to conclude my presentation, stenting of native coarctation of the aorta in adult patient is safe and effective, but it is related with reintervention in some patients. It can be more common in patients with bare metal stents implanted. And also bare metal stents resulted in greater decrease of the gradient during the procedure. Thank you for your attention, and I'm happy to answer your questions.
So proceeding to discussion, do we have any questions from the jury? Okay, so what was your own contribution to this work?
My contribution started from the data gathering, statistical analysis, presentation preparation, and also I have opportunity to be part of the diagnostic, mainly diagnostic. I can assess the diagnosis process at the unit, so I know the patients.
Okay, okay, thank you very much. So, summing up, all the submitted papers have been presented. We congratulate all of the presenting authors and participants of the invasive cardiology and cardiac surgery session. At this point, I would like to ask the president of the jury for a few words to sum up the session.
Thank you so much. We are very impressed. We have a chance to hear your excellent presentation. You are our future. You are our future of our university and the other high schools. Really, congratulations for all of you. And we're waiting for you in the next congresses. Thank you so much.
Professor Kalarus, thank you for these words. We would like to thank all of the members of the jury for your valuable comments, accurate observations, and work on presentation assessments. I would like, on the behalf of Student Society, Scientific Society, cordially invite you for the decoration and closing ceremony of the International Medical Congress of Silesia 2024, which will be held in Theatre Rialto tomorrow, on the 17th of May at 6 p.m. On the behalf of Student Scientific Society, I would like to thank you all for participation in this session. Thank you very much.